Aloha and welcome to our lecture today. We are going to talk about colostomies. And we're going to start out just by looking at some of the body organs and know that colostomies are mostly coming out of the small or large intestine. So I'm going to go ahead and put my glasses on here and we're going to take a look at this image that we've got here. We can see here that we've got the large intestine and we can see the small intestine. And so it's important for you to take a look in your textbook and make sure that you're identifying the different parts of the large colon or the large intestines, all right? We see the transverse colon, we see the descending colon and the sigmoid colon. Those are all parts of the large intestine. We can also see the ascending colon there. And then also in the center of this image, we can see the tubes that make up our small intestine. And our small intestine is made up of our jejunum. We also refer to the small intestine as the duodenum. And so here we can see parts of the small intestine. We're going to kind of look at them in a little more detail in the next couple of slides. But I want you to kind of start familiarizing yourself with these images. So here again we see the large intestine just by itself. We can see the ascending colon, the transverse colon, and the descending colon. And the sigmoid colon, which then connects to our rectum, which is then where stool is evacuated from. So when a patient needs part of their colon removed, we call this a colectomy. Okay, remove part of the colon, and that's a typo there. It should be an N, not an M. And so when a surgeon needs to go in and remove part of the colon due to some kind of disease process, could be due to diverticulitis, could be due to a cancerous tumor, oftentimes they will need to perform a colostomy in order for that bowel to have time to heal. And so colostomies can be permanent or they can be temporary. So they're done when the lower large intestine, the rectum, anus, is unable to function normally or needs rest from normal functions to heal. Sometimes an intestinal obstruction with an associated inflammation is a common indication for a colostomy. And in this image, we see an intestinal obstruction. In this case, it looks like it might be adhesions. Adhesions are when the bowel kind of sticks together. There's scar tissue. And remember, the bowels are a nice tube. Whether we're talking about the small intestine or the large intestine, we're talking about open tubes that need, the stool and the digestive contents to be moving through. If there's blockage due to scar tissue or a tumor, then we have a problem, right? We're going to have a patient who's feeling sick to their stomach, nauseated, probably vomiting, has no appetite, and we have to go in sometimes and do a surgical procedure. Now keep in mind that some bowel obstructions are partial, meaning that they're not fully obstructed, they're just partially obstructed. But indications for a colostomy, as I mentioned before, can be bowel cancer. A Crohn's disease is when there's inflammation in the digestive system. Diverticulitis is another condition that causes these small pouches to develop in the wall of the colon, and these can become infected and inflamed. And so what the colostomy does is it diverts the digestive waste away from the affected area of the colon to give them a chance to heal. And so in some cases, the colostomy will be formed after a section of the colon is removed. And here we see a descending colostomy where part of the descending colon was removed so that the terminal end is closed. And then there's a stoma that will be brought out to onto the surface of the abdomen to allow stool to pass. Okay? And here we can see the next step where that healthy colon is brought out through the abdominal wall and a stoma is created on the outside of the body. Oftentimes, there will be a Hartmann's pouch, which is the distal portion of the large bowel that is left or remains intact. Okay, so this is a pictorial view of the procedure. Here we can see the surgeon cutting off the tented skin where they're going to actually pull up the part of the bowel through the skin, and then they are going to surgically attach it, the stoma, to the outside of the patient's abdomen. So here we can see another kind of image where now we can see the large bowel coming up through and terminating on the outside of the body and the colostomy, and we can see the other part of the large bowel, the Hartmann's pouch, which has been left inside. Here we see another example of before and after. We can see the Hartmann pouch left in place, and now not only do we see the colostomy is on the outside of the body, but there's also now a colostomy bag that's attached to it in order to collect the stool. Here are some examples of some stomas. We see a stoma with one opening on the top, and on the bottom we see something called a double barrel stoma, and this is a stoma that actually has two openings. There's a proximal opening and a distal opening, and on this next image we can see what is happening underneath in the organs with a double barrel colostomy. We can see that both parts, in this case, of the transverse colon have been brought to the outside of the abdomen, and we've got two colostomies. Sometimes double barrels, they can be separated with skin, but sometimes they are just two together and they almost look like one because there's no skin in between. So this is an example of a double barrel colostomy, and one end of it is the mucus fistula. Sometimes the end of the inactive part of the bowel is sewn closed and left inside, and then there's only one stoma. And the mucus from the resting portion of the bowel comes out through the anus still. In a loop colostomy, it may look like one very large stoma, but it actually has two openings. So one opening puts out the stool and the other only puts out the mucus. The colon normally makes small amounts of mucus to protect itself from the bowel contents, and this mucus, it has to have a way to get out of the body. So either it's going to pass through the bowel, through the Hartmann's pouch, out the anus, or it's going to come out the other opening of a loop colostomy. But either way, we have to have a way for the mucus, which is going to be made regardless, exit the body. So despite the colostomy, the resting part of the colon will keep making mucus, and it has to come out either through the stoma or through the rectum and anus, and this is normal and expected. Okay, so here we can see a transverse loop colostomy. This is often temporary and reversed after distal colon recovers. So sometimes you will look at a colostomy and you'll see that there is this little loop underneath it, this little kind of, that it's looped, and underneath it is this little piece of glass or plastic that's kind of holding it up onto the skin. So here we see an example of a transverse loop. Here's another example of a loop colostomy, and yet another. Okay, so these are just some things that you might see when you're going to change a colostomy bag. So I wanted you to be aware of the different types of colostomies that you might come in contact with. I mentioned earlier that the colostomy will be named by the part of the bowel that it is associated with. So in this image, and nobody would have 4, but you would probably only have 1. But we can see an ascending colostomy, a transverse colostomy, a descending, and sigmoid colostomy as well. These are all large intestine colostomies. So for an ascending colostomy, there's going to be a stoma, an opening that's located on the right side of the abdomen that puts stool out, that drains from the stoma, and the stoma is, stool will drain from the stoma in a liquid form. And so one of the other things that's important to think about is that when you look at where the colostomy is on the patient's abdomen, it will give you an indication, right, of what part of the bowel has been manipulated and pulled out to make the stoma. Here we can see an example of what that ascending colostomy would look like on the outside of the body. In a transverse, you're going to have a stoma located in the upper abdomen towards the middle or right side. And the output that comes out of this stoma is going to be loose or soft because it's going to be, in other words, it's going to be a little more formed than what you would get with an ascending colostomy. In a descending colostomy, now remember, this is going to be located on the lower left side of the abdomen, and you're going to have a stool that is much more formed at this point, right? So the stool that's going to come out of the descending colostomy is going to be more formed and more solid. Here's an example of what a stoma looks like with the ostomy bag over top of it. Most of our ostomy bags are see-through so that we can make sure we can observe the stoma and make sure that it's healthy. All right, so right now we're taking a look. We can see here on these images the stomach. We can see the duodenum, which is the start of the small intestine, and then we can see the jejunum, which is another part of the small intestine, and we can see the ileum. And so in terms of colostomies for the small intestine, again, we're going to be referring to them based on which part of the small intestine has been manipulated surgically. So an ileostomy can be permanent or temporary. It's to allow the small bowel to heal after surgery, prevent waste from passing into the large bowel while it heals, used often in Crohn's disease and ulcerative colitis. And so here we can see that an ileostomy is coming from the ileum in the bowel. And what I want you to keep in mind here is that, well, I'm going to ask you, what do you think the consistency of the stool would be in an ileostomy? What do you think? What do you think? If you answered that it is going to be very watery, right, you are correct, because we are talking about contents after they come from the stomach, get dumped into the small bowel, and as it's moving through the small bowel, it certainly does not look like regular, normally formed stool, okay, because it's really in the very early processes of being digested. And so here we can see an ileostomy appliance located in the left lower quadrant. And the best way that you're going to know what type of colostomy it is by reading the operative report and finding out what type of procedure was done. Is this, an ileostomy? Is this an ascending colostomy? we have to read the report to find out that. The other thing we can do is maybe take a look at what kind of stool is coming out of it. That could be an indication as well. Here's some of the colostomy equipment that we use. We can see that there's some skin protectant that needs to go around the outer edges of the colostomy, the peri area of the skin. We can see that there's a wafer or a base plate that we use that usually has an adhesive on it, and a bag or a pouch that connects to the wafer. It almost snaps on like a Tupperware, snaps onto a Tupperware bowl. Here we also see examples of closure clips for the end of the bag. And there are lots and lots of different types of colostomy equipment and supplies, but these are some of the basic ways that we refer to them. Here we can see a measuring tool that we use to measure the size of the stoma. And what this does is it helps us determine the size of the wafer and how to cut it out exactly perfectly fitted so that it fits right over nice and close to the edges of that colostomy. And the purpose of that is to keep the skin as protected as possible, right? Because if stool irritates the skin, you're going to have some problems. And we're going to look at some pictures in a little bit of problems that can happen. So here we see the steps of changing a colostomy bag. We can see that we want to make sure that the outer skin is clean. We want to look at the colostomy itself, and we want to make sure that the stoma, right, is nice and beefy red. That tells us that there's good blood supply to the stoma and that it's a healthy stoma. It's getting good blood supply. So we want to observe the stoma. We want to observe the skin around the stoma. We want to measure the stoma. Then we want to cut out the proper size on our wafer. We want to put probably some skin protectant down, and then we want to place the wafer over the stoma to collect the stool once we put our colostomy pouch on top of that. Meticulous placement of our wafer is very important so that the skin is protected. Okay? Here we see an image of the wafer being placed very carefully over the stoma, and the next part is to put the bag on top of the wafer. Connect the bag to the wafer. Here's an example of a dermatitis, which can take place if any kind of digestive juices or stool or moisture ends up in that surrounding skin tissue. We end up with skin that is irritated, and this is something that we do not want to happen. So meticulous skin care is important. This part of the talk has to do with draining and irrigating the colostomy bag, right? So once the colostomy bag is full of stool, we need to clean it out and empty it. And this can be done a couple different ways, but we want to make sure we have the right equipment. So we want to get some chucks out, we want to get an irrigation syringe out, we want to have basins out to help us. It's also possible that the colostomy bag will get full of gas. And so we have to make sure that is released, right? That it doesn't get so full of gas that becomes too much pressure in there. So we have to release that pressure. So irrigating a colostomy bag, we need to be able to open the bottom of the drainage bag, and we need to be able to drain out the stool that is there. Here we can see that a colostomy bag is being drained, and interestingly enough, you might be saying to yourself, oh my goodness, that person is not wearing gloves. And I would say to you, very good observation, you are correct. I'd like you to know that oftentimes when we are teaching family about working with the colostomy bag of their family member, we don't necessarily teach them to use gloves. Gloves are costly. They may not be able to afford it, and it is perfectly okay for them to manage their loved one's colostomy bag using good hand hygiene. So it's very important to teach them how to wash their hands before and after they're managing the colostomy. And in fact, I would say that teaching them good hand hygiene is more important than anything, okay? So here we see it getting emptied. There's an irrigation syringe here. We could have filled this irrigation syringe up with some nice tap water, and we could have rinsed out the colostomy bag if we wanted to before sealing that back up. We use our basins for draining stool and also draining the water that we might use with an irrigation syringe to clean out the bag. Here we see an individual irrigating a stoma. And in this case, what they've got is it almost looks like an enema bag that's hanging from a pole. And they are actually irrigating the stoma itself. It's almost like they're kind of getting an enema, right, to kind of clean out the bowels a little bit. So this is irrigation of a stoma, and what's happening is the water is then draining out into the toilet. So nursing care of stomas. A lot of times we have someone called an enterostomal therapist, or sometimes a wound care nurse specializes in caring for colostomies. All nurses are perfectly capable, though, of learning how to manage colostomies, although know that there is a specialty if you're interested. The color and turgor of the stoma is something that we observe. We want it to be red and moist. Pale pink, again, might indicate that the patient's anemic or has a low hemoglobin. We want to be careful about too dark of a red color, okay? It could indicate bruising or ischemia. What we're looking for is a nice, bright, healthy, beefy red. We're looking for stomal height. So when the stoma is poking out of the abdomen, we want to make sure that it's at or below, we want to make sure that it is above the level of the skin, not level with the skin. If it is below the skin level, it can cause pouching problems, and it's difficult to get a good seal on the wafer, which means that we might end up with skin irritation, okay? So we want to make sure that that stoma is out and up a couple inches, half an inch, or more on top of the skin. We also want to identify the location of the stoma, the proximity of the stoma to the incision, right? Because if we have a fresh incision where the surgeon went in and did surgery, we want to make sure that that incision site, while still healing, doesn't get any fecal content in it, right? Because that's going to cause an infection. So we have to make sure that we're very careful about identifying where the incision is, where the waistline is, the abdominal folds or creases. Any bony prominences to the stoma will be factors when pouching is performed, okay? And then, of course, we want to always assess the peristomal skin, which is the skin around the stoma, and, of course, assessment and function. We always want to make sure that stool is coming out of the stoma, right? Because if stool is not coming out of the stoma, then there could be something wrong, and that needs to be reported immediately. So when there is a problem, problems obtaining a good seal, if the wafer doesn't stay sealed, a different type of pouch system might be desired. There's lots of different types of supplies, and if there are any concerns that arise from the family, there's lots of different options that we can use. If there's an increase in pain, in the abdominal incision. If the patient develops a fever, if there's any redness or drainage coming from the incision, that could be a problem. Changes in bowel habits, either a diarrhea or a constipation. More importantly, just something different from the baseline, right? So baseline, we know what's coming out of the stoma, and if anything changes, we want to make a note of that. And of course, skin irritation and a hernia may be noted. And this may appear as a bulge around the stoma. So let's look at a picture of what that would look like. This is a peristomal hernia. And what this means is that some bowel has herniated through the abdominal muscles into the area kind of like underneath the stoma. And so this type of a bulge is not normal. It's an indication that there is a hernia, and it may or may not be a problem. If it's something newly developed, the physician needs to be aware of it. Once the physician has assessed the situation, they can decide what to do about a hernia. It could be repaired, maybe if the colostomy is reversed, or sometimes people just live with them if they don't cause any problems. This is an example of some contact dermatitis around the stoma. This is an indication that the patient was allergic to the adhesive that was on the wafer, and that can happen. So you can see that it's very red, probably very itchy, irritated skin. Here we can see that the hair follicles around the stoma have been irritated. This is folliculitis, and so this is a little different. We have another image here that's showing a yeast infection on the peristomal skin. From warmth and moisture, yeast begins to grow, and this can be, of course, a problem as well. This is retraction. So a bit ago, we talked about the fact that the stoma kind of needs to be out on top of the abdomen and not retracted or level with the skin. This is a recession of the stoma away from the skin surface. This can be due to excess tension of the stoma, insufficient fixation, post-op weight gain, and so we definitely want to make sure that the physician is aware of this if this happens. We might try to use a rigid flange for our appliance here. And then on the opposite, what we might see is the prolapse of a stoma. And this is telescoping of the intestines through the stoma. If the stoma that protrudes 1 inch can become all of a sudden a 4-inch stoma, we want to make sure we notify the physician immediately. This may be due to increased abdominal pressure. And so we want to make sure we report this. Here we see necrosis due to lack of blood flow on a stoma. This is a major complication. This is necrotic. This is not functioning. This is dead tissue. So this is definitely something that needs to be reported immediately. Here we can see, this is actually a urostomy, which is another lecture, but I kind of wanted to show you this because this is what happens in a urostomy where there's urine pooling on the skin. And so these are just some of the complications that can occur. We will talk about urostomies later. The majority of everything we've discussed today has been about colostomies. And so this concludes our talk for today. I hope that you have learned something new about colostomies, how to assess them, what type of equipment we use to care for our patients who have them, and hopefully you will get an opportunity in clinical to work with a colostomy, and if not, I'm sure in your nursing career you most certainly will. So I hope you have a great day, and I will see you next time. Aloha.